Hi, welcome everybody to our research panel. Um, I'm excited to always put this together every year to share some of the research that's currently going on in New Jersey amongst our clinicians and our budding researchers. We have some great presentations today. We're going to have four different brief presentations talking about research that people are doing. Just to remind you, please save your questions to the end. At the end, write down your questions, and I know we'll have a chance to answer those for you. Thanks, and then we'll start with Dr. Moore.
Okay, so I'm going to go into screen sharing mode here now. Does everyone see my screen?
I can see it.
Okay, excellent. Thank you, Dr. Greenwald. Thank you to the Brain Injury Alliance of New Jersey for having me. Thanks for everyone for coming. My name is Matthew Moore. I'm the current Brain Injury Medicine Fellow at JFK Johnson Rehabilitation Institute. The title of my presentation is Low Vitamin D Level is Associated with Acute Deep Venous Thrombosis in Patients with Traumatic Brain Injury. So a brief introduction. Deep venous thrombosis, something very familiar to all the clinicians here, a blood clot of the deep venous system. These blood clots unfortunately have a risk of embolizing into the heart and into the lungs, causing a life-threatening pulmonary embolism. They do increase morbidity and mortality in inpatients and in patients in acute rehab where we deal with these patients especially. Here's just a schematic of what's going on in the deep venous system. You have the patient's right lower extremity. They zoom in on the venous system here. Usually with normal venous return to the heart, you have muscles contracting, some valves in the venous system that is able to pump the blood back up to the heart. However, oftentimes in certain patients, bedbound patients, injured patients, you do have stasis of the blood, which can cause clotting. That's in the second picture here. In the third picture, you see actually a piece of that clot break off, forming an embolus, which can travel up to the heart and into the lungs, which can be life-threatening. A little bit about DVT and some prior studies, especially with TBI patients. There was a 2009 study that showed that there's a 3- to 4-fold increased risk of DVT in TBI patients. A 2019 study last year, the number of days bed pound was a significant predictor for development of DVT in neurosurgical patients. Not all TBI patients that we see are surgical patients per se, but many are. It is mentioned that upon having a trauma or having a head injury, there are coagulation factors that can be released, causing increased risk for DVT. And there's many factors that go into DVT, immobility, weakness, multiple trauma, fractures, orthopedic issues. There's lots of factors that can add up that can put a patient at higher risk. This is our Child's triad. This is mentioned in the literature regarding DVT formation. You have venous stasis, endothelial injury, hypercoagulability. When you have all three of these, it kind of creates a perfect storm for formation of DVT. And unfortunately, a lot of patients in acute rehab, especially TBI patients, do have indeed all three of these. This is vitamin D itself. This is a 3D structure. I just wanted to show that. Vitamin D, a little bit of background on that. It is an essential nutrient. It has lots of functions in the body: calcium homeostasis, skeletal integrity, neurodevelopment. A lot of the studies out there about vitamin D are about calcium homeostasis and skeletal formation. However, that is expanding. There was a 2010 study that showed that 66% of outpatient rehab patients happened to be vitamin D deficient, and lower vitamin D levels were associated with a history of TBI, among other things. TBI wasn't the only diagnosis they singled out in this study. A follow-up study to that by the same group, actually, in 2011, showed that 77% of admissions to acute rehabilitation were vitamin D deficient. So I'm going to have numbers similar to that later on in regards to the TBI population, not all patients to acute rehab, but some of the TBI patients. 2 years ago, a study in 2018 showed that disability severity was correlated to vitamin D deficiency in severe TBI. So they talk about how the worse disabled you are, the more likely you're like to have vitamin D deficiency. Pictured here, this is the molecules that we're dealing with, vitamin D3 and D2. They are broken down into two metabolites, hydroxyvitamin D3 and hydroxyvitamin D2. The hydroxyvitamin D3 and D2 are actually what we're measuring when we do a blood draw. So during this study, when we measured vitamin D levels, we're actually measuring the metabolites themselves, not the vitamin D3 or vitamin D2. So in the past, DVT and vitamin D have been looked at. The question is there an association? There was a 2014 study that looked at hydroxyvitamin D levels, and it was associated with idiopathic lower extremity DVT with low levels. There was also a 2019 study that mentioned venous thromboembolism, which includes pulmonary embolism and DVT, had lower concentrations of vitamin T. So this has been looked at in the past in other populations. Some other rehab populations that we see, spinal cord injury and ischemic CVA. In 2018, there was a study which looked at spinal cord injury patients and vitamin D levels and DVTs, or venous thromboembolism, I'm sorry. And that study showed no significant difference in development of venous thromboembolism in vitamin D deficient patients. However, the 2018 study that looked at ischemic CVA did show an independently associated correlation with DVT, ischemic stroke, and vitamin D deficiency. So for this study, what were we trying to look at? We thought that low vitamin D levels, based on prior research, low vitamin D levels will be associated with an increased incidence of acute DVT in our TBI population here in acute rehab. We did a retrospective cohort study. Patients were admitted to acute rehab from December 2016 to December 2018, so it was over a 2-year period. Our initial database included 200 patients during that time period. We had demographic data, medications, vitamin D levels, results from a bilateral low extremity venous Doppler, and all this was extracted from an EMR. For the vitamin D level, this was usually drawn on the first full day of admission, usually with our admission labs. We used the threshold of 30 nanograms per milliliter to define low vitamin D level. This is based on prior studies that have looked at similar things. The lower extremity venous Dopplers were ordered upon admission. They were usually completed within the first few days of admission, usually the first 2 or 3 days, I would say. They evaluated for acute DVT in the thigh or calf veins, bilateral lower extremities, and sometimes incidentally found our chronic DVTs or superficial venous thrombosis. However, we did not find these significant for the purpose of this study because they're low risk to travel to cause pulmonary embolism and thus decreased morbidity and mortality with those. Here's a picture of what a venous Doppler looks like. You have the common femoral vein branching, and you have a femoral artery on top. You see good blood flow in the femoral artery and in one of the branches of the common femoral vein. However, the other branch is completely blocked off by a blood clot or a DVT. So our results, we ended up being able to have an N of 190 patients. The requirements for these patients, they had to have a vitamin D level on file and lower extremity venous Doppler results. The mean age of the patients involved, 65 years old. Average length of stay, 19 days. And there was 66% male population. So now looking into some of the data, Here we have a chart that looks at the frequency of low vitamin D versus normal vitamin D. So there was indeed a higher percentage of patients admitted with low vitamin D. 117 of the 190 had low vitamin D level for approximately 62%. Not quite the 77% mentioned in the prior study earlier, but 62% still significant. Normal vitamin D patients, 73 out of the 190, about 38%. Looking at the acute DVTs, we had 190 patients here. There, we found 30 acute DVTs, approximately 16% of the admissions. And then when we cross-matched those two values, we looked at the two groups. The low vitamin D group and the DVT and the amount of DVTs in that group was 24, and the normal vitamin D group, it was 6. So right away, it's a 4-to-1 ratio. You can kind of see something's going on here, even though the low vitamin D group did have more patients in it. The 4-to-1 ratio we do see here. On statistical analysis, we do see that this finding was significant using a p-value threshold of less than 0.05. So basically, what did we get out of this this study? We saw that DVT is increased in low vitamin D patients. The finding was statistically significant, but the question is why? Again, I take you back to Virchow's triad. A lot of these TBI patients, venous stasis, endothelial injury, hypercoagulability, a lot of these patients have this. Is the question of, is vitamin D level really affecting DVT or not? Does severity of injury matter? A lot of these patients have poor nutrition, low vitamin D because of that. They're not getting outside much, decreased sunlight, dysphagia, altered mental status, lower levels of ambulation causing increased risk of DVT, multiple traumas such as orthopedic fractures, and many other things that can be going on that cause greater chance for DVT. So what does vitamin D do? Does it have any anticoagulant properties? There have been some studies that have looked at this in the past. A 2010 study looked at polymorphisms in the vitamin D receptors, and they showed that there is a significantly associated with individuals experiencing post-medical and post-surgical DVT. A 2004 study also looked at the vitamin D receptor, stating that it may play a physiological role in the maintenance of antithrombotic homeostasis. A 2013 study, interestingly, looked at the general population, looked at vitamin D concentrations and increased risk of venous thromboembolism, and they did find that there was an increased risk of that with decreased vitamin D in the general population. As far as what exactly does vitamin D do, vitamin D upregulates thrombomodulin and downregulates tissue factor. These are two ingredients of the coagulation cascade that can cause clots to form. Thrombomodulin is a cofactor for thrombin. It reduces coagulation when expressed, and tissue factor initiates thrombin formation through the extrinsic pathway. So we've seen in prior studies that vitamin D does indeed impact clotting. Some future research or some future ideas that we could look at, I think we could expand on this study by looking at severity of injury, whether or not a moderate TBI or a severe TBI or a severely disabled person might have lower vitamin D levels or increased risk for DVTs. I think that's something we could expand on. Also, does vitamin D supplementation impact the prevalence of DVT in this population? That's something we kind of thought about doing. However, it was difficult to time when the supplementation was actually occurring in these patients. It's kind of something you'd have to start in acute care before a patient comes to acute rehab. The other thing was looking at vitamin D anticoagulation properties and seeing if there's any other involvement in that. So here are my references, and thank you to my research mentors, Dr. Golden and Dr. Greenwald. Thank you very much, everybody.
Okay, I'm gonna just share my screen. So I'm Lori DeBagian. I'm currently one of the physiatry attendings with Johnson Rehabilitation Institute at JFK. I spend some of my time at JRI doing outpatient spasticity and concussion management. And I spend primarily most of my time currently at Hackensack University Medical Center doing some acute inpatient rehabilitation consultation work. So the study that I'm going to talk to you guys about today is actually my fellowship study. I completed a brain injury fellowship last year at Kessler. So the title of my study is Transportation in Traumatic Brain Injury. It was an exploration into the usage, the advantages and barriers of e-hail in the TBI population. Just as a broad definition, e-hail or rideshare is what some people know as Uber, Lyft, or Via. And these are newer methods of getting around with on-demand access to transportation using smartphone apps. I personally was really intrigued by how we as healthcare providers can leverage this rapid rise of technology in our society to be able to provide the utmost care for our patients. So what I really wanted to look at was access to transportation. So access to transportation is important for two main reasons in the TBI population. One is it provides access to healthcare for our patients, and two, it provides access to everything else in life: community integration, independence, productivity, and employment. Traumatic brain injury patients have limited options for getting to medical appointments. They can drive themselves, but that can be dangerous. They may rely on their caregivers, but that depends on if they have them or if they're available. They can use ambulance services, which many of us clinicians know oftentimes run late. They can use public transportation, which may be difficult to navigate and has limited access, or they may just skip their appointments, which obviously isn't good for their health and healthcare. Interestingly, 50% of individuals who have had moderate or severe TBI never resume driving again. And lastly, from the viewpoint of a practicing physician, decreased appointment show rates due to lack of transport cause decreased productivity and revenue for physicians. So I was interested to see, could e-hail be part of the solution? Globally, e-hail is the fastest growing mode of transportation, expected to grow by 15% every year through 2030. It's really simple to use, and all you really need is a smartphone. Lyft, Concierge, and Uber Health have actually been created, and they're specifically targeting healthcare transportation. This allows healthcare providers to actually organize e-hail transportation for their patients. This bypasses the need for patients to even have their own smartphones. One study showed that e-hail has shown to improve medical appointment show rates by an odds ratio of 2.57 in low-income patients. But the next question I had was, what about accessibility? Uber and Lyft are actually not under the regulation of the American with Disabilities Act, as they claim to be technology companies and not transportation companies. In June 13, 2018, New York City settled a lawsuit with Uber, Lyft, and Via. E-hail companies now must service 80% of requests for wheelchair accessible vehicles in under 10 minutes and 90% in under 15 minutes or less by the year 2021. In 2019, Uber and Lyft said that they hit one of their benchmarks in New York City, that 60% of wheelchair users were picked up within 15 minutes and 90% within 30 minutes. Uber actually has an Uber Assist feature where drivers are trained to be able to assist those patients or people with disabilities. Uber has also launched Uber WAV in major cities including Bangalore, Boston, Chicago, London, LA, New York, Philadelphia, San Francisco, Toronto, and DC, Washington, DC. WAV or WAVE stands for Wheelchair Accessible Vehicles, and this is for people who have motorized wheelchairs or power scooters. So moving on to the study. The primary objective of the study was to find out, how does transportation affect access to medical care in the traumatic brain injury population? And there was three things I looked at, three purposes. One, to obtain preliminary data on the mode of transportation patients with TBI use to get to medical appointments. 2, to obtain preliminary data on the descriptive statistics of rideshare users in the TBI population, and 3, to explore the usage advantages and barriers of e-hail or rideshare among the TBI population. So for our methods, I created a survey called the Transportation to Medical Appointments in E-Hail Use Questionnaire. The inclusion criteria for our participants were adult men and women with history of moderate to severe TBI, English speaking, who could consent for themselves, and who were part of the TBI model systems 5 years post-injury and were living in a private or a group home. My goal during fellowship year was to obtain an N of 30, but due to time constraints, the actual sample size is an N of 10. The study was then conducted using the created survey and delivered over the phone. Demographics were then collected from the TBI model system database with the data from the most recent time point used. So if you follow along with some of the visuals here, I'll go through them just to give you the demographics of the 10 patients that were surveyed. So we had an equal amount of men and women of all different marital statuses who lived in all different living environments, urban, suburban, and rural. They had all different education levels, bachelor's degrees, high school, postdoctorates, and some college. And majority of the patient population was actually living with their family. So 9 of the 10 were living with family. There was a mix of employment status. So some were working full-time, others part-time, some were just volunteering, and others had no employment. And the age group actually ranged from as young as 30 to as old as 82 at the time of injury. And lastly, the patients had all different levels of injury, 40% severe, 20% moderate, and 40% mild traumatic brain injuries. And here's some of the results. So in regards to modes of transportation that were used to get to medical appointments, the most frequently used mode of transportation was family members driving their patients, and that was used by 60% of the sample. The next most common mode was patients driving themselves. So 50% of patients are driving themselves, which is consistent with the prior study I had mentioned earlier. E-hail is already being used by 2 patients, one who is using it often and the other who used it rarely. Other forms of transportation, such as patient transportation, taxi services, and public transportations were not used that often. In terms of satisfaction, 90% of the patients were very satisfied or satisfied with their mode of transport to their medical appointments, and 10% were indifferent. Therefore, no one was dissatisfied. Lastly, 20% of our patients had been late or had missed medical appointments due to transportation issues. The next part of the survey focused on overall e-hail usage, so not just for medical appointments. 3 out of the 10 participants used e-hail, with 1 person using it weekly and 2 using it every few months. I wanted to know what was e-hail used for. So I surveyed the 3 that actually use e-hail, and that's represented, if you look through to the figurines, that represents the 3 patients who were actually using e-hail. So 2 of the 3 used it to get to their medical appointments, 1 out of the 3 to get to social engagements, 1 out of 3 as backup if they had no other ride options, and none used it to get to school or to work. Next, I looked at the advantages and barriers to the use of e-hail. So for advantages, I only surveyed the 3 e-hail users, and you could see the frequency by looking at the check marks of their answers. So all the users, 3 of the 3, valued the independence, the ease of use, the on-demand nature, short wait times, and safety associated with e-hail. 2 respondents also said that they liked the fact that they don't have to handle money or calculate tip. Oddly enough, safety was also the biggest barrier for the entire sample population, with 30% of participants mentioning that as a barrier of why they wouldn't use e-hail. So barriers, we surveyed all 10 to see why they may not be using e-hail as an option. Wheelchair accessibility, cost, difficulty of use, lack of credit card, and lack of availability were also identified as barriers, but only by 10% of the population, the participants. Throughout the survey, many of the patients I spoke to really voiced their thoughts on the topic, and I believe this really captured the issue that's currently at hand. So I wanted to share just one opinion from one of the patients and what they told me when we were talking throughout the survey. And that patient mentioned, "I would like to do more on my own. The bus is a problem. I don't know where to call or go." So some of the limitations of the study, the TBI model systems database is obviously limited to patients who are admitted to rehabilitation. So therefore it misses those who may have had less severe injury or for whatever reason did not make it to a rehabilitation facility. 90% of the participants that were surveyed were actually living with their family. Hence, they likely have support which may impact their transportation options. Lastly, we sampled patients who were able to consent on their own, eliminating the caregivers from being able to provide their side of the story. I wonder if caregiver satisfaction would vary from patient satisfaction. So overall, the most frequently used mode of transport to get to medical appointments was a family or friend driving the patients, followed closely by patients driving themselves. 90% of patients were satisfied with how they got to doctor's appointments. 20% missed appointments because of transportation issues. I was unable to identify the descriptive statistics of e-hail users due to the small n. I believe that e-hail may be a great solution for traumatic brain injury patients that don't have family or friends or can't drive themselves, as it offers several advantages, including independence, ease of use, on-demand nature, short wait times, and safety. The main barrier is also safety, which needs to be overcome. This has potential to be a great option for physicians to incorporate into their practice to improve appointment show rates when people cannot drive themselves. In the future, I hope to be able to study this in a bigger sample. In our study, most people were independent or had good support, so I'd like to sample a larger population that may not fit those categories and therefore expand outside of the TBI model systems. I'm interested to potentially capture the caregiver viewpoint as well, and eventually consider a qualitative mixed method study to really identify issues in transportation for this population, so something like a focus group. I do want to thank the Northern New Jersey TBI System Grant, and it was Drs. Irene Ward, Anthony Lecarica, and Dr. JC who helped bring this study to life during my fellowship year last year. Thanks.
Good afternoon, everyone. My name is Sharon Bushy, and I'm currently the Brain Injury Fellow at Kessler. Please bear with me as I pull up my presentation, and thank you so much for everyone that's joined, and thank you to the Brain Injury Alliance as well for organizing this session today. So I'd like to take the next 15 minutes to speak on delirium in the inpatient rehabilitation setting, the prevalence and the outcomes, and I'll be focusing on the brain injury population as well through my presentation. I have no disclosures, so let's start by just defining delirium. This is defined in the DSM-5, and it's defined as fluctuations in attention and awareness, which occurs in a short period of time, typically hours to days. It's important that it not be explained, the changes that are seen clinically, by any pre-existing, established, or evolving neurocognitive disorder. And typically there's evidence with delirium of direct physiologic causes of disturbance. So medical conditions that cause it, substances, medications specifically, or the side effects to these medications. It's really interesting to kind of get familiar with the prevalence of delirium if that's not something that you're familiar with. Typically in the ICU, there is a varied percentage, but I would say most of the literature agrees with the higher number, 35 to 85%. But again, typically we see it more in that 80 to 85% range in the ICU. In the non-ICU acute care hospital setting, the prevalence varies to up to 50%. And previous studies done in the post-acute care setting have noted a 10 to 15% prevalence of delirium. Just to review what the subtypes of delirium are and how they present, typically there's three main types. There's hyperactive delirium, which you see at the top of the graph, which is presented with combativeness, agitation, and restlessness, as well as hypoactive delirium, which presents with lethargy, sedation, and stupor. It is also often seen where both of these occur together and can present with mixed delirium. One of the things that's important to note is that literature does state that hypoactive delirium with lethargy and stupor is typically underdiagnosed. So clinically, if this is something that you see, this is one that is important to just keep in mind so we don't miss it. So outcomes that are currently present in literature, this is a paper from 2010. Looking at a variety of post-acute care settings, including skilled nursing facilities as well as rehab settings. And they looked at both clinical instability, which they actually defined as abnormal vitals, as well as delirium. And here delirium was defined as a lack of awareness based on orientation only. And if you look at the graph, you see that the outcomes they looked at are transfers to acute care hospitals, death, as well as functional recovery. And in all of these outcomes, the population that was both clinically unstable with abnormal vitals with delirium tended to do more poorly, had more transfers to acute care, died, had more deaths, as well as had worse functional recovery, and all of these were statistically significant. Next, looking at the cost of delirium, and this is really an interesting point to make. This is a study from 2008, which shows month by month cost of a hospital group that's broken up into delirium versus non-delirium. And what you see is that the delirium group tends to be almost twice as costly per month. And this was thought to be most likely due to resources used both for the workup and treatment of the delirium. So given all of this information, we decided to create this study to really investigate the prevalence of delirium in an inpatient rehabilitation facility, which the one that we did it in is an independent IRF. Furthermore, I decided to take a closer look at the brain injury population and will present the related outcomes. One of our main objectives was also to evaluate whether delirium screening is a predictor for acute care transfers to the hospital from the inpatient rehabilitation facility. We used retrospective analysis using data from eRehab. The study population were all of the first admissions to Kessler Institute of Rehab at Chester in the year 2016. Our independent variable is delirium screening, and just to point out, the actual screening tool that we use is the 3D cognitive assessment method, or for short, 3D CAM. It's a quick assessment that consists of all of the main components of delirium, including awareness, changes in orientation, and changes from baseline of the patient. And it's been well validated in literature so far, and it is a quick assessment. Our primary outcome, again, is transfer to acute care hospital with secondary outcomes of functional independence measures, length of stay, as well as discharge disposition. I think it helps to just lay out a timeline of where this project came from. So this actually started back in 2013 when there was an internal quarterly review at some of the Kessler facilities, which highlighted delirium as being something that should be focused on. And so there was a workforce that was established, the delirium care formation. The next year, they decided to focus on delirium education. And at the same time, as I said, literature established 3D CAM as a validated measure of delirium. 2015, we did approve 3D CAM for delirium screening at admission at each of our Kessler facilities, which there are 3 main facilities. There were 3 main facilities at that time. In 2016, there was a review of all of the initial delirium screening at admission, and there was found to be excellent compliance, almost over 90%, specifically at the facility in Chester, and so data collection began. And 2017 is really when we started the process of data analysis to evaluate prevalence and outcomes, but the data is really so rich that we're really continuing to work on it even now into 2020 to better understand delirium in this setting. So let's move ahead and take a look at the data, which is really pretty rich with some information. I'm going to be presenting data from the total population as well as data specifically from the brain injury population. So to start with, here we're looking at a graph of the prevalence of delirium in the total population, which is about 1,400 patients in the year 2016 at Chester. And what we see is that the percentage of delirium falls within what was studied in prior literature. At our facility, it was about 9.1% or 142 patients. Just to note, the rest is made up of those that were negative for delirium, as well as a group that was unfortunately unable to be scored, and that is our unscorable group, which was about 4% in the total population. So again, looking at this in the brain injury population, the group that was positive for delirium on the 3D CAM was much higher than the total population, about 15% here. At the same time, the group that was unscorable was also much higher. About 11.2% were not able to be scored using this validated measure. And of course, this begs the question, why were they not scorable? And thankfully, the admission nurses were instructed to take notes on what made it difficult to score them. And this is in the total population. What we see is that the most common reason was difficulty with language, specifically aphasia. Patients with severe disorders of consciousness were not scored. Those that had any deafness or hardness of hearing. Some did refuse. Those with tracheostomy present, difficulty with speech, such as dysarthria, language barriers, and baseline dementia were all noted as reasons that patients were not scored. So now looking at the demographics, what are the characteristics of this population? This is the total population again, and we're going to go through it line by line. So age, those with delirium were older. However, this was not statistically significant. Those with delirium were higher percentage male. The number here being shown is the female percentage, but they were higher in male. Those with delirium were more men, and that is statistically significant. We did look at the primary diagnosis type, particularly if people were coming in with a neurologic injury versus a non-neurologic injury. Now, what's interesting here is that there is a statistic, it is statistically different, but when you look at the breakdown of the percentages, it's exactly equal. So those that had delirium were equally found to have a neurologic injury coming in and also not, which really indicates to physiatrists working in the rehab setting to be aware of delirium, even if they're not working with a population that has neurologic injuries. However, for the purpose of this presentation and for my work, I did want to take a further look at the brain injury population specifically. And what we see here is, again, somewhat of an older age in the delirium population, a much higher male percentage, which is consistent with literature. And then taking a breakdown of brain injury, stroke versus non-traumatic versus traumatic brain injury, what we see is that there is a statistically significant higher proportion of delirium within those that have traumatic brain injury. Looking at the functional measures now, across the board, this particular graph can be summarized by saying that those with delirium performed worse functionally, both in the cognitive and the motor domains at admission and discharge. But what's interesting is that those that were not scored performed even worse, and this is statistically significant. And looking at the brain injury population, it's pretty much exactly the same. So again, those with delirium had worse function, and those that were unscorable had the worst function, and this was statistically significant in both motor cognitive domains at admission and discharge. Now, looking at more of the outcomes, our primary outcome is acute care transfer, and we find a statistically significant increase rate, 22.5%, compared to those that did not have delirium. However, those that were unscorable had a fairly similar rate of transfers, 22.4% as well. Looking at length of stay, those with delirium had a longer length of stay, but unscorable had the longest length of stay. And again, with discharge to home, the percentage with delirium were discharged less to home, but again, the unscorable had the worst performance there, all statistically significant. Looking at this within specifically the brain injury population, very similar, all statistically significant, with the delirium and the unscorable population having a higher rate of transfer, having longer length of stay, and decreased discharges to home. One thing that I'll quickly note is looking at the functional measures again within the larger population, what we see here is that the middle column is those with delirium, and the green column is those that are unscorable. And what we see is that the gain in motor film actually decreases with delirium or those that are unscorable. And this really, again, makes it a point for physiatrists or other clinicians working in the rehab setting to be very aware of delirium, because it's clearly affecting not just gains in the cognitive domain, but also gains in the motor domain. And as I had reviewed earlier, that this is a condition that can occur even in those without neurologic injury. It's really important that we pay attention to it. Looking at a regression model, we found that in the total population, those that had delirium compared to those that did not had almost a 2 times odds ratio, or they were twice as likely to be transferred during their stay in the rehab setting, and that was statistically significant. And this is including confounding factors such as neurologic diagnosis, age at admission, excuse me, the gender, as well as the motor film scores at admission, which is a really strong reason, again, to be wary of delirium in the total population. Now, looking at outcomes within the brain injury population specifically, we do see an increased odds ratio, but unfortunately it was not statistically significant. But within all of the factors that were looked at, motor film scores or the motor function at admission was significantly or statistically significant, and should maybe be considered in this population. Just to kind of introduce this, the data in the total population was published this year, and this is the article in the PM Journal if anyone's interested. And I would like to take this time to just summarize some of what we talked about, and that is that the prevalence of delirium and associated demographics and outcomes are really fairly comparable to previous studies. Although we did use 3D CAM, which is a validated measure, which was unique to our study, as well as looking at this specifically in the inpatient rehabilitation facility setting. And what we see is that delirium is equally present in those with non-neurologic admission diagnoses as with those with neurologic admission diagnoses. And those with delirium had significantly lower gains in motor function, which is important to note. And they're twice as likely to be transferred to the acute care setting, which is something that's very difficult to patients as well as the healthcare teams taking care of them. In the brain injury population, we see that there was a large proportion that were not able to be scored that had significantly increased acute care transfers, which is most likely predicted by motor function, although delirium seems to be a contributing factor. And we do see that the unscorable population should be monitored closely. Limitations of our study is that 3D CAM was not reevaluated systematically after the admission. Results were not adjusted for interventions done for delirium, and as always, there's possible alternative factors contributing to the acute care transfers. As a result, there's really many future areas for study, including examining the difficulty of scoring delirium in the brain injury population, establishing continuous screening for delirium in the inpatient rehab population, and in that setting, and also exploring modifiable risk factors and what is being done for their management, including metabolic abnormalities, substance-related toxicities, and polypharmacy. And really, we need to assess the interventions and their associated outcomes. So these are my references, and I'd like to thank those that were involved, including Dr. O'Park, Dr. Barrett, the Delirium Care Task Force, Dr. Jacey, Dr. Lee, and Dr. Kirschblum. Thank you so much.
All right, sorry about that. Hello, good afternoon, everyone. Thanks for hanging in there. I think I'm the last one of the day, so hopefully I'll keep your attention here. So our study is entitled, Does Intrathecal Baclofen Therapy Lead to an Improvement in Impairments and/or Functional Limitations Experienced by Patients with Acquired Brain Injury, a retrospective study. My name is James Anderson. I also did this study with my colleagues Laura Fazzari, Heather Jarvis, Christina Lagsdens, and Sejal Patel. I wanted to give a special thanks to Dr. Yelena Golden for helping us with our data analysis, and I want to thank the Brain Injury Alliance and Dr. Greenwald for inviting me to present on this. So we're currently in the process of writing up our article, but we wanted to share with you our idea, our methods, and our results. Uh-oh, I'm trying to advance this. It worked in my, how do I, let's see, next. Okay, here we go. Sorry about that. So our learning objectives, identify the possible benefits of baclofen pump placement, interpret the possible side effects and risks of the pump placement, as well as scrutinize appropriate candidates for pump placement based on their clinical presentation. So why complete this study? So again, throughout, I've been working in JFK brain trauma unit, acute rehabilitation, as well as Hartwick at Oak Tree in Edison, specialized brain injury subacute unit. And through my 14 years of working in the brain injury population and my colleagues as well, you know, we were just uncertain about how much benefit patients are getting from baclofen pumps. Anecdotally, we haven't really seen a whole lot of substantial changes after pump placements. We see more a larger change during the pump trial, which is prior to the insertion, where they complete a bolus of the medication into the spinal canal. But we wanted to take a closer look at the objective data and to see if it's really helping patients, and then furthermore assisting us in educating our patients and families regarding it. So just a quick introduction about just spasticity in general. Spasticity is that velocity-dependent resistance to passive stretch. It manifests in response to an upper motor neuron injury at the cortical and spinal levels. It occurs due to upper motor neuron overactivity from disinhibition from vestibulospinal and reticulospinal tracts in the brainstem, or hyperreflexia from uninhibited lower motor neurons. And it can certainly interfere with comfort, positioning, hygiene, function, and in turn, quality of life. So there are numerous interventions that could be used to manage spasticity, and one such intervention is what we chose to study, the intrathecal baclofen pump therapy. It's a programmable pump that delivers baclofen intrathecally, typically into the lumbar spine. Intrathecal just means injection of medication into the spinal canal or into the subarachnoid space so that it reaches the cerebrospinal fluid. So prior to this study, research has shown that intrathecal baclofen therapy does improve spasticity and some of the secondary complications, such as pain, range of motion, ease of hygiene and positioning in certain populations. However, there is limited research supporting functional outcomes in the brain injury population. So the overall purpose of our study was to review functional outcome data in this population and use the evidence to assist in determining optimal treatment plans. And as we said before, education of patients and families to allow them to make an informed decision about that type of treatment. So other forms of spasticity management that are usually performed prior to having to go to do a pump would be obviously physical therapy, but aggressive stretching and serial casting, particularly on some of those distal musculature, particularly the ankles. And those casts can be made into bivalve splints eventually. And it's much more effective when pharmacological interventions are on board as well. And particularly for that type of treatment, you know, things such as phenol nerve blocks or Botox injections are very effective because they work locally for that particular muscle or two. But when you have something that is more global, you need a global treatment. So oral medications such as oral baclofen can have that global tone reducing effect, but also has a side effect of increased drowsiness, which can increase or decrease performance in other tasks. And again, the intrathecal baclofen is generally reserved for patients with very severe spasticity. So just a couple pictures of what a pump looks like if you haven't seen it. It's about the size of a hockey puck, roughly, and that's what it looks like there. This would be the level generally that they insert the pump into, right there between L3 and 4. And just a different perspective there where the pump is pretty much placed in the abdomen and a programmable, like a Bluetooth type device would be able to change the dosage as needed. So possible benefits and reasons. So all those other interventions mentioned earlier, they're just ineffective or you're getting less than optimal outcomes. Generally, the way I think of it is intrathecal baclofen pumps are for three main reasons: pain, hygiene, and function. So pain, when somebody has that severe spasticity, they're in near constant pain. So even if we can't improve function, can we improve their quality of life? Is there a significant decrease in pain? Hygiene, I put an example. Sometimes patients are so contracted or very tight that there's no real space for caregivers to get inside, like for example, in their elbows or knees to clean them properly. And then we see periods of skin breakdown, bacteria building up there. So allowing for improved hygiene and ease for the caregiver. And function, and that was again a question, is it improving function or can it? So some possible side effects, it goes the opposite way. You'll go from hypertonia to hypotonia. Your muscles are too loose. And sometimes patients are using that hypertonia for function. So extensor tone is more common in the lower extremities, and sometimes patients use that tone to help give them some support when they're doing standing tasks. So sometimes their tone is actually benefiting them. So you don't necessarily want to prescribe that for every single person. It depends on the situation. Other things are nausea, vomiting. It can cause sleepiness, drowsiness, and that again can interfere with cognitive function. Research has shown previously that the baclofen pump doesn't affect that as much as like an oral medication, but again, we've seen in the clinic that it's not necessarily the case. Headache, upset stomach, and dizziness are other side effects. So other risks from it, lots of things can happen. It's a surgery. Catheter or pump could move inside the body. The skin that's over that pump could start to break down and get irritated. Pump could stop because the batteries run out or problems have occurred with one or more of the inner parts of the pump. The catheter could leak, tear, kink, or become disconnected. And that would result in an underdose, which if somebody's been on a high level of baclofen and all of a sudden they're not getting it, that could lead to withdrawal, and that could be a medical emergency. And surgical complications are possible and include infection and spinal fluid leak as well. The surgery can be reversed and the device can be removed if it's not effective or if they do get any of those complications. Dosage starts slow and low and slowly ramped up to avoid the overdosing. As I said, it's very easily wirelessly programmable. It's very critical for the interdisciplinary team approach in these types of patients, and all patients really, but particularly these patients, to continuously communicate with all members of the medical team, monitoring the patient's presentation, observing for any complications, and also talking to and advising the medical team as a therapist, I'm talking here, when patients may be ready to have an increased dosage. In other words, they're still too tight, spastic, or increased tone. So our hypothesis was that in the acquired brain injury population, there's evidence that it does improve spasticity, which can result in improvement in pain, range of motion, positioning, and ease of hygiene. However, it does not correlate to a significant improvement in functional status. And this is just based on our years of clinical experience of all the members of my clinical research team here, and our experience with working with patients with baclofen pumps. So our patient population, patients with acquired brain injury admitted to our specialized brain injury subacute at Hartwick at Oak Tree in Edison, and they had to have their pump placed between 2005 and 2015. So we excluded patients with comorbidities that affect normal muscle tone, patients with pump malfunctions or new medical events post-pump insertion, or patients that had progressive or degenerative disorders were excluded. Our age range was from 17 to 67, with average age at time of insertion was around 35 years old. Our final sample size was 15, which we started at around 60. And our breakdown is almost half is traumatic brain injury, about a third is anoxic, and the remainder is CVA and other. And the majority of the patients were male, which coincides with most traumatic injuries. So our methods: 10-year retrospective study. As we talked about, a standard data collection form was developed and used for data collection from the patient's charts. This was a really long process. We have no electronic medical records in our building, so all of them were paper notes, big banker boxes full of old medical records. It was kind of sorting through needle in a haystack at times, so it took us a long time to collect the data. It was a tedious process. Our outcome measures include the modified Ashworth scale, the JFK coma recovery scale revised, as well as range of motion and functional status levels. Our results: there was no change in functional status as our hypothesis stated. However, as we said, this was not expected because most of our patients had low-level functionality to begin with, as well as other impairments such as poor response to multisensory stim and cognition, etc. We got large effect sizes and significant p-values for spasticity of hip flexors, hip extensors, and hip adductors. So we had approximately a change of 1 whole grade in the modified Ashworth scale in each of those muscle groups. So that's statistically significant, but also clinically significant. No significant change in the more distal musculature for spasticity or in the upper extremity musculature. No significant changes with passive range of motion other than knee extensor range of motion, which is like an outlier, and we're not quite sure about that. And no significant changes in coma recovery scale scores. But because it's a pilot study and we had a very low N at the end of everything, the study's underpowered, so the significance is a little less than we expected in those areas. And a larger sample size would definitely better answer our target question in the study. Oops, sorry about that. Sorry about that. Oops. Okay, so considerations and limitations in our study. No systematic assessments. We were, again, sorting through these old documents. A lot of the time it was incomplete or no data available. And part of that process too is that this was over the course of 10 years. We had many different therapists documenting, and therefore we had a lot of inconsistencies with our documentation. Dosage considerations, there was very poor documentation throughout of dates of the changes in the dosages. A lack of standardized survey assessment on caregiver burden and quality of life, which would be a good possible future research topic. lack of diversity of the functional ability levels. Another future study, so, again, generally baclofen pumps are reserved for the very severest of cases usually. It would be interesting to see in a more moderately impaired population if function would improve in those populations. We attempted to measure pain and comfort, but again, very inconsistently documented. So again, that's the drawbacks of this type of study, going back and hoping that everything was documented properly. Some patients received therapy after the pump, some did not. So some were off a formal program and on a restorative nursing program when they had finally received the pump. And the reason is there were long time lapses from when the pump was recommended by the team and pump placement due to scheduling procedure, medical issues, and insurance approval. And so use of those adjunctive therapies simultaneously, some got them, some didn't. So again, another possible area for future research. And our small sample size, we only included patients that had reevaluations 32 days pre and post pump. And again, we did this to see the most direct effect from the procedure. So overall, our conclusion, this study reinforces the findings in some other studies in other patient populations that intrathecal baclofen therapy can improve spasticity, particularly in those proximal muscles. We believe it's a promising study, and we think of it as a conversation starter. And it's by no means the question hasn't been fully answered, and more research needs to be completed on this underserved and understudied population with obviously much more subjects. And a prospective observational study would allow for more uniform data collection and more consistent documentation in the areas of interest, an example of pain, as well as limiting the study to 1 to 2 researchers to help prevent any inter-rater reliability issues. And another thing about our conclusion, so is the pump the complete solution to everything? No, obviously, but could it be a tool to help patients cross a threshold at that impairment level, at that spasticity level, that would then allow patients and therapy rather to progress them further at a functional level? Potentially, again, based on the level of cognitive impairment that they're starting at. Also, potential for effectiveness with less severe cases in regards to function. Hopefully being able to get enough research that maybe expand patient population that could benefit from such a pump. And again, we're hopeful that these future studies with larger sample sizes could continue to examine the true effect of pumps in the acquired brain injury population. And that's it. And here's some of my references. Thank you very much.
Thank you all so much. So I did end up getting some questions. There is one for Lori. So the question is, are there any evidence-based interventions that assess safety training / attitudes about safety and use of e-hail and public transit for people with brain injuries?
That's a great question. Not anything that I know of. Part of the reason I kind of delved into this for my research was there's such a scarcity of information out there for topics as such, but nothing specific that I know of to it in regards to evidence-based interventions.
Okay. And another question, I don't know if you'll know the answer to this, but I know that not all medical facilities are using these type of Uber and Lyft applications, but how would patients be able to access e-hail in a medical setting?
So that really depends. So a patient themselves, if they have the ability to have the smartphone and just like you would do it, to go catch a movie, you would just call the e-hail service to wherever you're from, put the location of the hospital, and then vice versa on the way back home. Specifically with things like Uber Health and Lyft Concierge, it's administration that actually, there's platforms where the administration would actually set up the rides for you and contact the drivers for you, and therefore do it without you as a patient ever having to worry about any piece of it. Oftentimes in those settings, the cost likely is coming from the administration or the practice. So they're likely covering the ride fees. But again, with the hope that the loss of productivity and, you know, the money you would lose from the patients not making it to the appointments or having missed shows would be offset by that. So it's a completely different platform in that case. Otherwise, the patients can just do it just like anyone else would be able to. I don't know if that's exactly what the question was asking.
Yeah, yep, that's great. Thank you. And then the next question is for James. The question is there similar pumps with other types of muscle relaxers? Is there similar studies on those or baclofen that you've seen?
Generally pumps that I've seen in my experience and just through looking up research prior to this is generally reserved for baclofen, but I don't know if they're developing anything new. And one other thing, when I had like a little glitch in my presentation, I just wanted to say one other thing. So that significant change in those proximal musculature, if it didn't necessarily lead to function, it can help in other ways. Again, hygiene, range of motion, but also like caregiver ability to move their legs during care, wheelchair positioning, improved posture, interaction with the environment. So even though it didn't have a direct relationship with function, it can definitely give these patients a better quality of life. And I wish I had a better answer to the question itself, though. Sorry.
Oh, that's great. And James, another question, where would someone that would need this type of procedure, where would they go to get this service?
Right. So, I mean, they'd have to follow up with their primary caregiver, and then I imagine get referred to a neurosurgeon that would insert the pump. And obviously they would, I mentioned in the very beginning, you know, to make sure you don't go through with the procedure first, they want to do a trial. So they do that bolus as a trial directly into the lumbar spine, and you do a pre and post test. So you'll definitely be able to see at least the response to the bolus. And to see if it's worth going through, because as you heard about all the different side effects and potential risks, it's not something you just go into lightly. Yeah, I would imagine, I mean, they get it in our facility because they're being attended to by a physiatrist who can refer them to a neurosurgeon. So I would imagine an outpatient would have to get referred by their primary physician to a neurosurgeon to potentially explore that. I know it's a specialized area, the surgeons that perform that, so they'd have to get referred to one of them.
Okay, great, thank you. We can wait a few more seconds just to see if anyone has any other questions. So I'll just wait a little bit. If not, then, you know, I want to thank everyone for being on this webinar today. And I guess if there's no more questions, this will conclude our workshop. I just ask if everyone can please complete their evaluation